Congenital deformities. Congenital malformation can be caused by development aberration in utero, environment, influence, radiation, exposure, rubella, syphilis, human immunodeficiency, virus, or hereditary condition. Overall incidence of congenital malformation diagnosed within 5 years of birth is 23 per 1,000. Some of more common disorders are clubfoot, spina bifida, and hip dislocation. Congenital deformities. Metatarsus abductus, valgus hindfoot, unilateral externally rotated leg, internal tibial torsion, or an adducted thigh with internal rotation of the leg are conditions thought to result from utero position, and this may also be contributing factor in the pathogenesis of Talipes equinovarus clubfoot. All of these conditions, except Talipes equinovarus, generally respond to passive stretching exercise, with corrective casts being necessary only refractory cases. Congenital dislocation of the hip. Congenital dislocation of the hip is a serious condition if not diagnosed and treated within the first week of life. The incidence varies from rise to rise, but is approximately 1/2 per 1,000 live births in European nations. Girls are affected 8 times more often than boys. The left hip is affected more often than the right, and the incidence is higher if relative is affected. 1/3 of dislocated hips have an abnormality of the opposite hip as well. Diagnosis. The diagnosis is made by clinic examination and routine postnatal examination assists by ultrasound examination. Radiographs are unhelpful because their femoral head doesn't start to calcify until the age of 10 weeks, often later. Several tests are described: Barrow's Simulate Click, Ortolani's Heinz Hip Click, von Rosen's, all very similar. Examination of every newborn hips in the north at birth is essential and effectively detects of majority of dislocated hips. Successful treatment hinges on early diagnosis and intervention. On examination, a hip click, Ortolani sign, elicited as the hip reduced in acetabulum with flexion and abduction of the thigh. A similar click Barrow sign occur with dislocation of the hip by abduction with gentle posterior pressure. The gluteal fold will be asymmetrical and the affected side appears shortened when the knees and hips are flexed to 19 degrees. Alerts CRC. Without Napiers and the femur held between the thumb, the forefinger. The hip is abducted and the femoral head moved backwards and forwards relative to the acetabulum, it est, and down relative to couch. If the hip is unstable and unmistakable, thud of jolt is felt as the femur moves in and out of the acetabulum. If undetected, the child will have a noticeable pain or waddle when beginning to walk. Periodic follow-up examinations of the hips in newborns during the first few important. And the hip will disappear with the limitation of abduction being the most obvious abnormality. Increased lumbar lordosis will be present as in arthritis and adolescent. Correctly performed test will definitely the child will have noticeable limb of waddle when beginning to walk. Periodic follow-up examination of the hips in newborns during the first few months are important, and the hip click will disappear with the limitation of abduction being to the most obvious abnormality. Increased lumbar lordosis will be present as the child begins to walk, especially in bilateral dislocations, while the degrees of dysplasia with subluxation of shallow acetabulum without frank dislocation can also occur and are a cause of symptomatic degenerative hip arthritis in adolescents or young adults. Correctly performed, this test will identify almost every unstable hip, but there are two exceptions. The first is very small groove in which the femoral head slips slowly out of the acetabulum during the first year of life. And the second is the very usual hip, which is irreducible at birth. Abnormal click are found in about 20 per 1,000 live births at immediate postnatal examination, but fall to about 6 per 1,000 after 2 weeks. Ultrasound examination allows the hip to be placed in one of 4 categories. In most centers, the examination and advise the high-risk hips It asks babies with a click on clinical examination, a family history of congenital dislocation of the hip or other predisposing factor in ultrasound shows the hip to be dislocated or the acetabular roof to be looping a splint or mass is applied and retained until ultrasound shows the hip is reduced. In the newborn, the secondary center of ossification of the femoral head is absent and usually advanced by 4 to 6 months, although there is a very wide range 2 to 10 months. When present, the ossific nucleus should be within vertical line from the acetabular median talking line. The below a horizontal line draw through the radiate growth plate cartilage of the acetabulum. Again, right. The right hip is held in the position of adduction compared with the left. The line parallel with the roof of the acetabulum intersecting. Hugin-Rein's line indicates an acetabular index of 48 on the right and acetabular dysplasia. Right proximal capital femoral epiphysis is much smaller than the left and is laterally displaced. The acetabular index in the angle of the acetabular roof with Hingeland's line and normally should be 22 degrees. With congenital dislocation of the hip, this angle is increased and can be as high as 30 to 40 degrees. With the hip in induction, the femoral neck fails to point towards the radiate cartilage and Shenton line. A smooth arc from the lesser trochanter on the femur, continuing along the neck and inferior cortex of the pubic bone, is discontinuous. If the ossific nucleus is not present, and arthrogram of MRI scan with readily demonstrate the dislocated position of the femoral head. It is better to treat 100 patients needlessly in this way than miss one patient with congenital dislocation of the hip, even those incorrectly applied bandage which holds the hip in excess abduction can cause a septic necrosis of the femoral head. Treatment. Treatment depends on the time of diagnosis. Of sooner the diagnosis, the easier the treatment. In the neonate with congenital dislocation of the hip usually can be reduced in the flexion and abduction. And treatment is a splint or brace that can maintain this position. The Paulich harness and von Rosen splint are two of the more commonly used devices. Flexion of the hip should be 90 to 110 degrees with slightly less than maximal abduction. Treatment is for 3 to 6 months until the acceptable development is normal. In congenital dislocation of the hip diagnosed in the first few months of life, abduction bracing can also be successful, but radiographic evaluation is needed to be sure the hip remains reduced. In children under 18 months of age, close reduction after 1 to 2 weeks of skin traction can be attempted under anesthesia. If concentric reduction can be obtained as judged from radiographs or arthrogram, the patient is placed in the double hip cast with the hips flexed to approximately 100 degrees and slightly less than full abduction. Can impair the blood supply to the femoral head and lead to avascular necrosis. Adductor tenotomy can facilitate their reduction. In children whom closed reduction can be obtained. Open reduction they performed using a anterolateral approach, or in children less than 24 months of age, using a medial approach to their hip. The Anterolateral approach in all the children facilitating femoral shortening when necessary to achieve reduction. The child is placed in the bilateral hips, speaker cast with the hips in the position described above and maintain the reduction. Persistent acetabular in children between 2 or 5 years old can be corrected by eta recapsula, Pemberton of immunimate salta osteotomy. More extensive procedure such as the Chiari eliminate osteotomy are occasionally necessary to obtain superior acetabular coverage of the femoral head and all the children. Thus, if congenital dislocation of the hip is diagnosed within the first week of life, it can be corrected by a splint or harness which holds the hip abducted and flexed. One study showed then the condition was far common in North American Indians who raped the babies in a papoose, then in racially indicated Eskimos who carried the babies on their back with hip abducted and flexing. And plants such as the Cambridge spleen, Pavlik harness, or von Rosen spleen of the hips in the same position and will achieve a stable hip if one correctly for 20 weeks. Twelve weeks. The pelvis is then examined radiologically to confirm that hip is reduced. If the plain radiograph is not conclusive, an arthrogram is performed. the hip satisfactory and 12 weeks, the joint is likely to be totally normal, but the child should be reviewed regularly until skeletal maturity. The patient can be discharged, but should be urged to check her or his own children's and grandchildren's hips for dislocation. At 2 months, if the condition isn't diagnosed as those, it may be identified or routine examination. 8 weeks later, when they should be apparent from the restriction of hip abduction, congenital dislocation, hip diagnosed at this age can be managed conservatively with traction and plaster immobilization. At 12 to 18 months, if the dislocation isn't on at the 8-week examination, the diagnosis will probably be missed until the age of 12 to 18 months, when the child begins to walk with a limp and rolling gait. The diagnosis can be confirmed of clinical examination because there will be shortening of the limb, the foot will be externally rotated, the skin greases asymmetrical, and Trendelenburg signs positive. At this stage, the hip cannot be made perfect, but a series of operations will usually achieve a stable joint, although at the price of great physical and emotional upset for the child and the family. Because the prognosis is so much better if the diagnosis is made early, special care should be taken with neonatal examination. The missed congenital dislocation of the hip is disaster. The only patient who can lead a moderately normal life with a dislocated hip are those with both hips dislocated because the problem is then symmetrical. Torticollis. Torticollis or wry neck is now seldom seen, but once occupied much orthopedic time. The condition is a result of excessive stretching of sternomastoideo during delivery, and improved obstetric care has reduced its incidence dramatically. The area of damaged muscle contract to form a firm fibrous mass in the muscle known as sternomastoid tumors. Let's go. The head is pulled progressively over the one side by the tight contracture of sternomastoid. Treatment. Physiotherapy is only effective in the first year of life. If the deformity persists, the sternomastoid must be released from the clavicle and the head held in the corrected position until the patient no longer tilts it. The operation should be done early for two reasons. Growth change produce a very old, asymmetrical face. The eyes come to walk in the position and the head tends to revert to that position.